my IVF answers. So today we have Dr. Llaneza with us from Tambre Clinic in Spain, in Madrid and Alicante. They're advanced reproductive medicine clinic, and who offer a very wide range of treatments, but also specialize in specific areas such as reproductive immunology, reproductive genetics. So we're going to have a wonderful conversation today. Now, please do send in any questions that you have, and we will try our best to get them all answered. For any questions that can't be answered, they will be sent to myivf.com, and they'll be sent to Tambre as well, that hopefully we will do our very best to get your questions answered. So just a very quick little bit of housekeeping before we begin. So when you do ask questions, they will be anonymous. So please don't worry about your name being called out. These are going to be, we're live on YouTube. This recording, because this is being recorded, will be almost instantly put up onto YouTube when we're finished. But 24 hours later, it will also go up onto myivfanswers.com. So I'm delighted to be able to introduce to you now Dr. Llaneza. Thank you so much, Dr. Llaneza. And I'm going to get rid of my video, and I'm looking forward to listening to this talk as well. So thank you very much.
Well, thank you for that very kind presentation. As you said, my name is Ángela. I am a gynecology specialist in reproductive medicine, and I work at Clínica Tambre at Madrid. Today we're going to talk about a very interesting topic, which is moving from egg donation after IVF. Yeah, that's right. Thank you. That's a very interesting topic because right now egg donation is the only treatment we have available to treat severe advanced maternal age and low ovarian reserve once we've tried everything with the patient's own eggs. So it's the most effective treatment we have, and it's very important that you know as much as possible about it before embarking on a new procedure. So this is the index we're going to follow during our conversation today. We're going to see what's the IVF, what happens next, most common causes of IVF cycle failure, treatment options, egg donation step by step, AI fertility, and real success stories and patient cases, which might be the most interesting theme from today's talk. IVF, what next? So, as you know, IVF, and especially when we do either with a conventional IVF fertilization technique or with an ICSI, which is the standard technique to fertilize the eggs nowadays, is the most common assisted reproduction technique, and many patients do start here. IVF is often the first step, but not always the final answer, as we were anticipating in the introduction. Cycle failures can be emotionally, physically, and financially draining. Moving from IVF to egg donation is not a defeat, it's a strategic evidence-based decision. And today we'll explore this transition, when this transition is recommended, how it works, and if it might be the right option for you. What are the most common causes of IVF cycle failure? The main cause would be the embryo. As I said, we have 3 patients, normally the male, the female, the partner, and the embryo. And actually, the embryo is responsible for most of the failures. So embryonic abnormalities do account for the main cause of failures: low ovarian response, no embryos are obtained, poor quality, male factor, poor embryo morphology, transfer on day 3 and day 2, we do know that are less successful. Chromosomal abnormalities, that's the most frequent cause of implantation failure and early miscarriage. We know that sometimes endometrial receptivity and uterine abnormalities might also be responsible for a failure, problems in the uterine structure, fibroids, adhesions, etc., or alterations in the implantation window. And some coagulation and immunological disorders might either prevent an embryo from implanting or increase the miscarriage rate. What are the treatment options in the egg donation? Well, the indications are low ovarian reserve, advanced maternal age, low oocyte quality, hereditary diseases that cannot be detected with PGD, with implantational genetic testing, repeated miscarriages or multiple failed IVF cycles, and poor response to ovarian stimulation. How does Tambre select its female donors? The selection criteria is established by the Spanish Fertility Association. Egg donors must be between 18 and 35 years of age. The minimum height is 1.55 meters, and the body mass index must be normal, less than 30. There's a first visit that takes place with the donor unit. First, there's a psychological interview, and if that's fine, we move ahead with the medical testing, where we make sure that they're healthy, that there are no medical conditions, no hereditary diseases. We explain the process, and obviously we do perform some genetic testing. We always confirm that the candidate, the donor, has a normal female karyotype, and we rule out some of the most frequent recessive conditions. As I said, the first step is a psychological interview, and then we move forward with the medical testing. As you can see here we can see some of the tests we perform: blood count, blood group, and the rhesus test, biochemistry, infectious disease testing. We perform gynecological testing, ultrasound scan, follicle count, pap smear, vaginal swabs to rule out sexually transmitted diseases. And we do perform genetic testing, karyotype, recessive conditions, cystic fibrosis, alpha thalassemia, Meissner deafness, and the X fragile. And optionally, we could perform a genetic compatibility testing between the partners, the partner of the recipient, or with the donor, in case a double donation treatment was necessary. The donor selection is very important, and as you know, egg donation in Spain is anonymous, and the choice of the donor is based on the physical resemblance. We need to respect the recipient's physical features. So, well, that's a very rigorous and thorough selection, okay, based on everything we've said. Then, in order to choose the donor, we will ask you to send us pictures from you in the present time, from you in around your 20s. Everything is assessed by the egg donation department, and they also use a tool which is called Fenomatch, which is an AI tool which provides a lot of objectivity to the selection process, okay? And through this software, we are able to compare the physical features and choose the most adequate donor. And additionally, as I was saying, optionally, a genetic compatibility testing to decrease the risk of having a newborn affected by a recessive condition could be implemented as well. In some cases, we do need to also use donor's sperm. The main indications are poor semen quality or azoospermia, genetic conditions in the partner, single women or a couple of women. In some occasions, also, even though we could potentially work with a sperm sample, when we've seen low blastocyst yield in several cycles, sometimes even several cycles in egg donation, we might suggest moving to donor sperm. When it comes to the male donors selection process, it is the same as we do with female donors. The only thing that changes, obviously, is the andrology test. We confirm a normal sperm count. We perform a semen culture, urine culture, and we perform a PCR to rule out sexually transmitted diseases as well. In this case, we will confirm a male normal karyotype, and we will perform the test to rule out the most frequent recessive conditions. And also, additionally, we could perform a genetic compatibility testing even between donors in double donation treatments. So there will be, here we can see an itinerary, first a step-by-step program. So there would be a first phase when we do the consultation and we perform the analysis of the partner. Okay, we have a diagnosis. We need 6 to 8 weeks to find the donor. Okay, and then around 10 to 14 days to stimulate the donor and retrieve the eggs and prepare the sperm. Once we have the donor and the eggs and the sperm, we will create the embryos. Normally, we will use an ICSI technique. On the next phase, we move to the embryo culture. As you know, the standard culture right now of the embryos is day 5, day 6, blastocyst stage. Normally, less than 50% of human embryos are able to become blastocyst. So the first thing that we need to do to have a transfer with high potential is to work with blastocyst. So we're going to keep our embryos in culture until day 5, day 6. And if we do a synchronous cycle between the donor and the recipient, we will perform a fresh embryo transfer, single embryo transfer, and we'll freeze the rest of the embryos. And if we are doing a non-synchronous cycle, okay, we will freeze all of the embryos. And on a subsequent cycle, we will begin the recipient's endometrial preparation to perform frozen embryo transfer. Once again, single embryo transfer. Normally, after the embryo transfer, we require 11 days before being able to do a blood test that will tell us whether the embryo transfer has been successful. And once we have a positive result, we ask you to perform an ultrasound scan, transvaginal ultrasound scan, to confirm the pregnancy, its viability, and its location. As I was saying before, right now the standard day to transfer the embryo should be the blastocyst stage. Less than 50% of human embryos are able to become blastocysts. Until day 3, the embryos live off the oocyte, and from day 3 on, they need to express their own genetic material, which is called genetic imprinting, and less than 50% of human embryos are able to do so. And the ideal best standard of care practice is to transfer one embryo at a time, single embryo transfer, especially after 40. Okay, so that's normally what we do and what we advise you to do. At Tambre, we've incorporated AI in our daily practice. So right now, all of our embryos, unless you choose not to, they go on a time-lapse incubator, get into incubator. So the embryos are put in this incubator and they're kept inside until day 5, day 6, when we're going to use them either for a fresh embryo transfer or to freeze the embryos or to do a genetic testing, which could also be done on a neck donation treatment. The main advantages of this type of embryo culture is that we won't be touching the embryos and changing their culture, their culture conditions, because the embryologist can see the embryos through a screen, because the embryo is observed 24/7. And at any given moment, if the embryo wants to know more about the embryo development, obviously that's recording a video, so they can fast forward, go backwards, and see how the embryo has gotten to that point. And the most important thing, as I was saying, is that we won't keep the temperature, the oxygen, the culture conditions. Okay, so by being able to record the embryos and its development, obviously nowadays we can apply AI tools to improve the embryo selection that has already been done. And there are a few companies working in that field, and we've chosen to work with one company, which one Fertility and the Chloe software. And actually, we are very happy because by using AI, we might be increasing the accuracy of our decisions when choosing what embryo to transfer. First, obviously, this field needs more research, but it looks indeed very promising. And right now, it is a very important tool that supports the decision the embryologists, the people, our professionals are making. So, this first part of theory being explained, obviously, I would like to share some success stories and patient cases with you. This is the first one. After many attempts, her baby finally arrived. Maria was 41 years old and had undergone 3 embryo transfers with her own eggs unsuccessfully. Her ovarian reserve was very low, as might be physiological at that age, and the few eggs that were retrieved in each cycle did not lead to good quality embryos. In one cycle, she didn't have blastocyst, and in a subsequent cycle, she did have one blastocyst to test, but unfortunately, it was aneuploid. So after 3 failed rounds, from failed rounds, she decided to move to egg donation. In the first cycle, we obtained one excellent embryo, one blastocyst. We did a fresh embryo transfer, and there was an ongoing pregnancy at the first attempt. This is quite frequent on an egg donation treatment. Normally, the success rate per transfer is around 50%. So she did have a baby with that fresh embryo transfer, and they froze 3 extra embryos. And right now, they are the embryos are in storage, waiting to maybe increase the family in the future. It was a very beautiful case, Maria. I remember her, and that's actually one of the main indications that we see patients coming either from Spanish patients or patients coming from abroad after failed IVFs to do an egg donation treatment at our clinic. The second case is about Laura. Laura is 38 years old, had experienced 2 miscarriages after IVF and 1 additional failed implantation. Further evaluation confirmed advanced maternal age with poor quality, which were significantly reducing her chances of obtaining healthy embryos. Her medical team back in France recommended egg donation as the option with the highest likelihood of success. Once again, we did a single embryo transfer. In this occasion, it was a frozen embryo. She didn't want to be bothered with the preparation, so we created the embryos. The partner came, provided the sperm. We worked with frozen sperm, frozen eggs. We created the embryos. We freeze them all, and once the embryos were ready, Laura started her preparation. We did a frozen embryo transfer with hormonal replacement therapy. And the pregnancy is ongoing, and it is going very well, and we stay in touch, and we look forward to meeting the boy. It is going to be a boy, and well, they have a couple of names in their minds now. So this is another very usual case that we see, maybe younger patients, but failed IVFs. They don't want to try any longer with their own eggs, and they want to move to the most cost-efficient treatment, which would be egg donation. So we move to egg donation, and eventually it works. And the last case is a case that I wanted to bring today, which is recurrent implantation failure solved with a comprehensive approach, because it is true that sometimes before moving to egg donation to an egg donation treatment, we want to use all the available options, and sometimes in a lot of developed countries, unfortunately, the most advanced reproductive medicine technologies are not available. So in this case, this is Anna. She's 36 years old, has a lower reserve and 4 failed embryo transfers despite good-looking embryos, beautiful embryos, but question mark regarding to the ploidy, to the chromosomal status of the embryos. She came to us, and obviously, given that the ovarian reserve was low, but the patient was still young, had a good ovarian response within the context in past cycles, we recommended a double stimulation with PGD-A testing, which revealed abnormalities in most of the embryos. However, we were able to obtain one euploid embryo. And before going ahead with the embryo transfer, only one embryo available for transfer, we wanted to perform all the complementary testing available, just to avoid second thoughts and make sure that everything was okay before transferring this precious embryo. So we perform time meta testing to assess endometrial receptivity and be able to personalize the exact timing of the embryo transfer. Also, this test includes a microbiome testing to rule out dysbiosis and chronic endometritis. And we provided a consultation with an immunology specialist to develop a tailored treatment and try to use add-ons that could help with the embryo implantation. We did transfer this euploid embryo, and luckily we had a positive pregnancy test, and now we have an ongoing pregnancy which is going very well and now reaching the term. So we're looking forward to hearing back from Anna. And well, I wanted to say obviously that egg donation is sometimes is the last treatment, but sometimes we are actually, before moving to egg donation, we are actually able to provide a more extensive approach to try to give you higher chances with your own embryos before moving to the egg donation treatment. Thank you so much for your attention. And if you have any questions, I look forward to hearing from you. And my colleagues at Tambre team will contact you, will be more than glad to contact you if you contact them through that email address and the phone number. Thank you very much.
Thank you so much for that fantastic information. As you would expect, we have a number of questions, so I'm going to start calling those questions out now. So, and you kind of touched on this at the end there. At what point do you move on to donor eggs and give up with your own eggs?
So that's very subjective. Actually, that changes from patient to patient. What we know is that after 4-5 IVF treatments with the patient's own eggs, it is less than likely that we will be successful in future attempts. And the other main indication is advanced maternal age, which is now considered 43. After 43, the options with the patient's or own eggs are less than 5% in most of the cases. So the advised treatment is egg donation. So obviously, those are the clearest indications, but I've seen everything. I've seen patients at 30 not wanting to undergo an ovarian stimulation and asking for a double donation or an embryo adoption, rejecting the possibility of undergoing an ovarian stimulation and therefore moving to an egg donation. And the opposite, patients with 6-7 failed IVFs who want to still try. This is still medically feasible, because when it is not feasible, we're not going to go ahead with the treatment, and we try to provide those patients with more options, as we can see on the last patient case that I brought to you.
Wonderful, thank you so much. So following from that, and again, as you say, probably subjective, how do you deal with the emotional aspects of changing to donor eggs, or how do you see your patients dealing with that?
Well, obviously, there's a lot of that process that is done from indoors that I don't see. As I always say, moving to an egg donation is a path. For some patients, it is very straightforward, and they don't need to think much about it. And for some other patients, it does require a lot of psychological work. might be a year, might be 2 years, but it does require a work and most with psychologists and sometimes with friends, with patients, through patient communities, and in most of the occasions, eventually after that personal work, egg donation is accepted as a possibility. But our advice is always to let yourself work through that and follow your own pace whenever it's possible, before moving to the egg donation treatment. But as one patient who actually runs a patient community back in France said to me, to her, the realization was the fact that if she didn't move to egg donation, she wouldn't be able to have children on her own. So that made it very, very clear to her. But I've had patients, a very small percentage, less than 5%, who did not consider that option or were not able to finally accept that option. Yeah.
Okay, thank you very much. When traveling abroad from ICSI, so I think they've already had ICSI in Germany, 12 unsuccessful transfers with the female factor being endometriosis and male factor. Now the question has jumped away, but I do remember male factor had an issue with I think poor movement and abnormal shape of the sperm. So when do you move on? When do you decide that you are going to have to move on at that stage? Or should they consider still trying with their own egg and sperm?
Well, after two unsuccessful embryo transfers, the egg donation is going to be the advice treatment. Obviously, in these occasions, we do have a very detailed consultation with the patients. Then we make them go through everything they've gone through, the type of embryos that have been transferred, how are they feeling psychological, the financial aspects of the treatment as well. So probably from a cost efficiency point of view, egg donation would be the advice treatment. But as I said, for example, in this case, coming from Germany, we know that the law is very restrictive there, that when it comes to the technology, they are still, and what's available, they are still way back compared to Spain. So in cases like that, after a very important discussion, some patients do want to try, and we're able to provide them with a more comprehensive approach, and in some occasions, a successful approach with the patient's own eggs. When it comes to the male factor, in this case, alterations in the sperm quantity, unless obviously we do not have spermatozoa, or alterations in the sperm mobility in themselves, are not an indication to move to a double donation. So we always want to see, despite how altered a spermogram might be, as long as we're able to find a spermatozoa, we are always going to try to work with the sperm, because the sperm and the spermatozoa is more resistant than the eggs. So for me, actually, when I do advise sperm donation in the absence of not having a spermatozoa, obviously azoospermia, okay, is when we have several cycles with lack of blastocyst, okay. Obviously, we are always going to ideally want to try with top quality eggs, which would be egg donation eggs, before advising a double donation in this case. But as stenoteratospermia in itself, that's not an indication to move to a double donation.
Okay, wonderful. Thank you so much. Before considering egg donation, do you recommend women over the age of 40 should try using DHEA with their own eggs?
Sorry, say again, please, before
Of
trying.
course. So before considering egg donation, do you recommend women over the age of 40 should try using DHEA supplementation whilst using their own eggs?
Well, DHEA has not proven to improve the egg quality. So that just using that and see if that improves something wouldn't be an option. Obviously, as I say, we need to go through their clinical records, see what they've done, and see if there's something that we can try to do best. But unfortunately, no supplements, no preparation, no protocol has proven to improve the results. So that well, I wouldn't ask her to delay an egg donation just to try with the HCA before an ovarian stimulation based on the evidence nowadays.
Wonderful, thank you. I'm 43 with AMH at 2.3, never had IVF before, been suggested to do ovarian PRP and hysteroscopy and implantation cuts. Too scared thinking about it. If any of these steps are beneficial or unnecessary, I am trying with my own eggs.
Well, so for we need to see for parts this part. So first thing is the MH is not the same. We're talking about MH of 2.3 nanograms, or which would be very good at 43, or 2.3 picomolls, which would be a low, however normal value result at 43. So in any case, we know that in one case we might have a low ovarian response to ovarian stimulation, which is going to limit the number of eggs that we have to work with. Whereas if we had a normal ovarian reserve, we might be able to have more eggs. Still, the critical point here is 43, but because we know that at 43, most of the embryos that are going to be aneuploid. However, obviously, after going through everything and discussing everything in detail with the patient, probably we would accept undergoing an ovarian stimulation, given that the patient has not had any previous treatment. Okay, and then we need to see what can we do to improve the results. So, as I've already said, there's nothing, unfortunately, we can do to improve the quality or substantially change the number of eggs that we're going to retrieve. There are a few strategies that are discussed nowadays. One of them, very well known, is the ovarian PRP, the platelet-rich plasma. However, this technique is still experimental nowadays, meaning that it has not proven to improve the prognosis. And in my opinion, if this technique was going to be useful and used, and nowadays most of the very well-known specialists in reproductive medicine do not advise to use it, okay, but still, if we were going to use it and if we were going to maybe have some benefit from it, probably it would be in younger patients. So I would not advise her to undergo PRP. That to what concerns the ovarian stimulation, and then the hysteroscopy and implantation cuts. Yeah, well, that we don't do it. Would be when it comes to implantation. All these are very experimental approach, done in somewhere in the south of Europe, not in Spain. I'm going to say this is gonna the Greek approach, Czech Republic. This is all. This is not evidence based. And obviously, the key thing here would be to have a euploid embryo. If we're able to obtain a euploid embryo, normally success rate is between 50 to 70%, the miscarriage rate less than 10%. But obviously, if we have that embryo, we're going to try to make you all the available testing before transferring the embryo. But any intervention in the uterus, scraping or cuts, the metroplasty when it is not indicated, needs to be discussed with the patient because it is not risk-free. So we need to be very, very careful with that. So, well, I've been very, very clear in my answer.
Brilliant, thank you. So we have one here asking, how do you select the donor in Spain? If I'm from the UK and have different skin color, different hair color to Spanish ladies, how do you go about, and I think you answered it, but just so we can re-clarify it, how do you go about selecting for that individual?
Yeah, we both have very, very different phenotypes. I might be more Mediterranean Spain-like, and you might be more UK type. So actually, we have everything, okay, from Spanish people, and we are able to respect the features, okay. and your features wouldn't be a problem, okay, because we do have a donors that would match you. Special phenotypes even we are able to match them. So well, it's just that might require more time, but normally in max 3-4 months we're able to do the treatment, and here we're talking about very maybe less frequent phenotypes, red hair, green eyes, O negative blood type, but we do not have any problem with that. Obviously, we ask you to send pictures. We ask you to fill in a form answering the questions about your physical features, so you can say what is your eye color, and then we use the AI software, Fenomatch, that I told you about before, and it works fine, and we're able, even though you're not maybe the most frequent phenotype, but we have donors with that would match your phenotype. Yeah.
Wonderful. Thank you so much for answering that. So we have 2 questions left. If anybody else wants to send some in. My IVF doctor showed me a graph pertaining to chromosomal abnormalities in which women aged below 25 show more prosperity versus women above age 25. Is it better then to find a donor older than 22 years of age?
Yeah, it is true that there are a few research that tell us that there might be a peak in a euploidy at between 20 to 25, and after 35, especially after 40. That's true. But when it comes to the success rate, right now in all the general evaluations, we say less than 35, and we do not make any differences. I mean, we say that the success rate is highest when in patients and donors younger than 35, and nowadays we do not make any distinctions between 20 to 25. There are not different tranches, or how you say, intervals of patients, no. So right now it is like that in our own data, and we have a lot of indications for PTA in even in egg donation, and we haven't seen anything abnormal. So I'm not concerned about that.
Wonderful, thank you. And the last question then is, how far up the chain do you start investigating immunology? So reproductive immunology, when does that come into play?
And depends. If we follow the guidelines, very late. If we follow the guidelines, that would be after 3 euploid failed embryo transfers, or after 3-4 untested blastocysts. So this is obviously in the ideal world, but in the real world, sometimes if we don't do it before transferring a healthy embryo, after one failed euploid embryo, we perform complementary testing, included immunological testing. And in egg donation, my personal approach is after the second failed embryo transfer.
Thank you. We have one more question snuck in. I hope that's okay.
Absolutely.
Does the live birth rate significantly decrease with age of the recipient with egg donor, let's say from 40 to 50 years old? Are the pregnancies more at risk as the age increases?
Does the live birth significant with the age of the recipient? No. So actually, once we move to an egg donation treatment, the age is no longer a prognostic factor when it comes to the success rate of the embryo transfer, if we're doing an egg donation treatment. A different issue is the obstetrical and fetal complications during the pregnancy. So normally, we've set out a cutoff of at 45. Obviously, as the maternal age increases, there's going to be an increase in the maternal morbidity, preeclampsia, hypertension, diabetes, premature delivery, fetal restricted growth. We do know that. So the first thing we do to avoid to decrease the risk is obviously transfer one embryo. Then patients go general health testing. And as I said, the cutoff, the cutoff where we see a insignificant, because thankfully, thanks to the great obstetrical care in the countries that normally work with, still the percentage of important complications is very low, less than 5%, thanks to the great obstetrical care. But probably that will be 45. So in patients over 45, we do perform some extensive testing, cardiovascular function mostly, which is the most important thing. And obviously, we make sure that the patient is healthy, and we rule out chronic conditions that could significantly increase the risk. But as I said, as long as we're transferring one embryo and the patient does not have any pre-existing significant condition, and the patient has access to great obstetrical care, which is the normal situation in in the European Union, UK, US, countries where we're working, and the patients do try to get the best care available after going through an IVF treatment, regardless of their location. Thankfully, we can never say that nothing will happen, okay? But when complications arise in obstetrics, the most important thing is act at the very pertinent time, and we are able to do so, and therefore prevent important or more severe complications. So
Wonderful. Thank you, Dr. Llaneza. What superb information. If I was a patient and if I wanted to come to the Tambre Clinic in Spain, how would I begin that process?
Well, the first thing would be to get in touch with our patient team to book an appointment, and we could do that online. Or if you wanted to see the facilities, get to know me or one of my colleagues, and also use that trip to provide a sperm sample and maybe skip a future trip, you could come and have an in-person consultation, and we can do one day trip and testing.
Wonderful, wonderful. Thank you so much, Dr. Llaneza, for so much wonderful and valuable information. Absolutely. And for anybody who wants to watch this again, it will be live on YouTube almost instantly, or in 24 hours on myivf.com. But for now, Dr. Llaneza, thank you so much again. And thank you for everybody who's been able to watch. And I know that you'll be able to have gotten some wonderful information from this talk. And hopefully we will see you all again soon. Bye-bye. Take care.
Thank you so much, Liadh. Thank you. Take
Thank
care.